You are now.
All right, sweet. Hello, Dental Hacks Nation. We have a very interesting podcast for you today, kind of a roundtable about a topic that we use every day that maybe isn't as sexy as some of the topics we talk about, but it's super important. So I'm here with my stalwart companion, Dr. Jason Lipscomb. Jay Lips, how you doing?
Hey, everybody. How you doing?
So we're going to talk about sticking stuff to teeth today. Pretty excited about that. And we have two smart people to join us, which is good because Jason and I we're going to do a lot of listening today.
I'm not one of those.
I think, yeah. So we have with us first, we have Dr. John Weston coming from La Jolla, California. John, how are you?
Very good this morning.
Excellent. And then we have from 3M, his name is Dylan Johnson. He's an engineer. He's one of those guys that figures out how stuff sticks to teeth better than other teeth. Dylan, welcome to the show.
Hey, thanks for having me on.
So what I kind of wanted to talk about today was what kind of cements we need to have in our practices, where they're used, how to simplify it, how to have as little complication to it. Because here's the thing. Over the years, between bonding agents and cements and different types of, it can get complicated. And I think restorative dentists would like to make things as simple as possible. So we're going to have to talk a little bit about cement types. We're going to have to talk about the different kinds of things we're trying to stick to teeth and where to use what and why and all that stuff. So knowing that that's the case, I guess let's just dive in. I'm going to ask John, what cements do you have in your office and why? What kinds of cements, I should say?
Yeah. I mostly use resin adhesive cements. I mean, for me, I want things to stick as well as they can stick. I don't want to have to think about, using a cement that's, less strong than another one as far as adhesion goes. So I have a basic cement for, cementing my traditional crowns. Then you need kind of a system that will allow you to cement crowns that don't have as much mechanical retention, but would still be traditional type full crowns. So crowns with short prep. So I have a system for that, using bonding agents in addition to the resin cement. And then obviously we've got our dual cure stuff for crowns that are too thick for light curing issues and putting posts in and stuff. And then I have my full bonded light cure type cements that I use for real thin porcelain type restoration. So
sure.
I keep it pretty simple. I'm down to, 2 or 3 at the most, and usually 2,
mm-hmm.
A light cure and a dual cure resin. And that's pretty much, that covers everything for me.
Okay. Interesting. Now, just for fun, when you're doing your regular day-to-day kind of stuff, what materials for, let's say for posterior crowns, what materials are you going to most of the time?
Well, in the past, obviously we were using a lot of metal-based, PFM type crowns and things
mm-hmm.
like that. But now it's pretty much all ceramic, either Emax or zirconia. I would say in the last 5 to 7 years, we've gone almost exclusively to some type of zirconia for molars, if we can get the aesthetics that we're looking for. And then, so that's kind of my traditional, back tooth crown. Anything in the aesthetic zone, we're doing in Emax or layered Emax or even feldspathic on some of the anteriors. So those are the 3 materials I primarily use. And we're doing a lot of big cases. We probably do a couple thousand restorations a year, all ceramic. And everything's, we're using a digital format to do that last time, so we can track things pretty easily. So, I think we were up to, something like 3,000 zirconia restorations the other day we looked at. So doing quite a few, and then probably double that when you get into ceramics.
Okay.
One of the things that always throws me a little curveball in my practice, and I see some dentists talking in the Dental Hacks Nations about different restorations, is Maryland bridges and of the sort. I don't know if you do many of those. I've seen a lot of people talking about that recently, and a lot of times I get confused about what the best thing to use is and material as well. So what would you say to somebody like me?
Very interesting question, because in the past they didn't work well, especially on upper arches where
I've seen a lot of Maryland bridges. Mostly I see them in the palm of the hand of the patient where it was placed. That's the story.
You're exactly right. it's a problem. It's hard to bond, metal. You can do it. It's just not as successful. So you need some mechanical retention. But an interesting concept that we've been doing for the last, I would say, I spoke on this about 7 years ago, was using zirconia on the wings. And zirconia doesn't bond real well either. That's a problem. So we're actually pressing a little bit of porcelain to the inside of the zirconia wings and then bonding that to the enamel. And that's
interesting.
Really, really successful. So that takes a lab that knows what they're doing and a little bit of planning, but it's possible to do that. It just takes a thin layer of porcelain that you can press to the inner side or the intaglio surface of the zirconia, and you can bond that with great success.
Interesting.
So that's all we do when we're doing Maryland bridges now is zirconia framework, resin bonded porcelain. So.
I'm going to step back a little bit because I want to start with the simplest crown cementing for dummies there is, and I want Dylan to tell us a little bit about this. First off, what about when you have a gold crown, a porcelain fused to metal crown, I'd argue maybe even a regular plain old zirconia crown, and you want the simplest, most straightforward? Is resin reinforced glass ionomer, is that still the go-to? Where does 3M come down on that?
That's a great question. Definitely, we would recommend a resin modified glass ionomer for those cases. So in your cases of gold crowns, porcelain fused to metal, stainless steel, you have a lot of mechanical retention with those types of materials, and a resin glass ionomer works perfect in those situations.
And the tough part about that is it's been working really well for a long time. It's not new. Right. So when you go to the shows and you're seeing it's not new and sexy, but dang, it works really well.
It does. And there are a lot of features and benefits with using a resin modified glass ionomer. It's very moisture tolerant. It's easy to clean up, really easy to cement and go. And it has that fluoride release, which a lot of doctors are looking for as well.
So tell me about that. Is the fluoride release a real thing, or is that a selling point because it's a glass ionomer and fluoride's going to be released anyhow?
There are some clinicals out there that do indicate that fluoride release can be helpful. And that reaction between the FAS glass and the polycarboxylate acid, it definitely releases fluoride over time. And so it's a continued fluoride release as that GI reaction progresses down the line of the cement setting.
Interesting.
And Dylan, I said no big words on the interview.
Yeah. That's
no.
Well, I mean, I've been working with Wendy Briggs, a hygiene consultant, and she's been talking about using fluoride at a crown delivery. So is that material able to uptake that fluoride and put it back into the tooth at all?
Sorry, it cut out there for a second. Could you repeat that quick?
Sure. So I'm working with Wendy Briggs, who's a hygiene consultant, and she's advising fluoride treatments at a crown delivery. Does that material able to uptake that fluoride and
So in terms of glass ionomers, there's an ion exchange between the tooth and the material itself. So as there are more ions available, whether that be the calcium or the fluoride, there would be an ion exchange between materials and the cement as well.
And also you mentioned too, it's those materials are very moisture tolerant. I think I struggle with this. Is how dry is too dry?
It's a great question.
Yeah. So, and maybe John can jump in here after I explain a little bit, because I'm sure he has some tips and tricks on that. But, in terms of a resin modified glass ionomer, you definitely want water to help facilitate that reaction, especially that glass ionomer reaction. When you start talking about, self-adhesive resin cements, they do want a little bit of moisture, but excess moisture is going to start to cause a little bit of problems, and then as you move towards an adhesive resin cement, pooling of saliva and blood and other contaminants, that's going to definitely affect your overall bond strength. So in terms of moisture tolerance, your GIs and your RMGIs are the go-tos in those types of situations.
John, when do you use a resin, do you use like a luting cement like that still?
Yeah, so, I did until the class of self-etching adhesive resin cements came out. And then I just found that, the benefit, I just didn't find the need for the resin modified glass ionomer as much. I mean, sure, we used to use pure glass ionomer back in the day and mix the powder and the liquid.
Good times.
But as soon as the adhesive resin cements and the self-etching adhesive resin cements came out, I found I just didn't grab it as often. For me, the window of time that I need for a restoration to be dry enough to cement is so short because
Mhm.
you can do a 1-second cure on a lot of these cements, like I do with, I want to use the resin, the self-etching adhesive cement I'm using now. It's a 1-second tack cure, buccal lingual, and it just
Mhm.
pops off. So I need the tooth, dry and clean for, all of 10 seconds, 15 seconds, and I'm fine. So I haven't needed to use the resin modified for isolation reasons, and I wouldn't really use it just for the fluoride release, because a well-sealed restoration is as good as that. So
Exactly. It's one thing when you're using it as a restoration. It's very much another. You're kind of hoping that your crown fits so well that you don't have a lot of exposure of that cement to anything. So
yeah, so I want the best adhesion. That's the first thing when you ask me what I want something that's going to stick the best I can get. So if I can use a resin cement, I'll just do that. And I just haven't really followed that trend of a lot of people kind of staying with that traditional luting sort of.
we should talk about that. Okay, so here's the thing. I had a chance. I've been using the Reliax Luting Plus, but also using some of the Unisem 2 in the last couple weeks. And what's surprising to me, okay, I used some resin. So the resin cement handling used to be the problem. Like I didn't want to go to that because it was technique sensitive. There's a lot to it. You had to do special stuff. Well, shoot, Unisem 2 is the instructions are essentially the same as the luting version. So actually, it's really funny. The luting cement, which is the glass ionomer, the basically it says you can light it for 5 seconds. Now tell me this, Dylan. Let's be honest. It's not light cured. It's heat. Is that right?
No, so there is a light curable.
There
portion.
really is.
Yes,
Okay.
there is. Yeah, so it's a photo initiator is in the cement.
I didn't know that. Okay, okay.
And so that helps the cement gel up, and so that resin portion that's in that glass ionomer is photo curable.
Okay.
So
okay.
when you tack cure that for 5 seconds, buccal and lingual, that's the portion that's actually curing itself, and then that allows you to remove the excess in one easy piece.
I'm finding, and it might be my light, but I'm finding I need a little longer than that to get it. So I always figured it was just kind of the heat that it was looking for. But I will say this, Unisem 2 in a similar situation, as John mentioned, like 1 second, maybe 2 is about enough, and you're clearing that.
Yeah, in fact, if you go much longer than that, you'll have some challenges clearing
interproximally.
And so I started using Unisem when it was in a capsule and it was in a triturator, and we've just moved on now to where it's just the greatest cement I think on the market. But I'm not here to promote that. That class of cement is a really good class. But the biggest hack I could probably share with people is when you use a resin cement is don't mess with it. Seed it, let the overflow stay there, but spot tack for a second, and you can pop that off, and it's clean. And literally, sometimes our crown deliveries are literally, 2 or 3 minutes, and the crown's in place and cemented. So then we'll let it sit and finalize. We don't obviously start, doing a lot of things with it. But as far as cleanup, super quick, super easy, super clean. And that's kind of what moved me away from the RMGIs. I didn't need that easy cleansability for me, because with the spot tacking on the resin cement, you get more adhesion and an easy way to clean up. So why not?
It's funny because, like I said, I've used different resin cements and have stuck with the RMGIs because of it's been an easy, straightforward cleanup. Now, like I said, Unisem 2, using the instructions you just talked about, cleans up very similarly, which is a little different. And thus, here's the thing, I've had to cut off zirconia crowns that I put on with an RMGI. They're not going anywhere. I mean, if you got a prep that's got any kind of structure to it all, you're cutting those things off like they're it. I couldn't tell the difference between a bonded one and not one because they're tough to come off. Right. So I get plenty of retention from an RMGI. The difference was, of course, with a resin cement. It used to be like it was enough of a hassle. I'm like, I'm just going to use this. But I would argue that Unisem 2 is moving towards that. So then the question is, how do you treat the material, the crown that you're putting on? Do you have to treat it differently? Do you have to do anything special to the inside of it? Do you have to do anything special to the tooth, anything like that? So Dylan, explain that a little bit with the luting plus first, so the RMGI, and then the other. So
like Unisem 2?
Yeah.
And this might even be a good point to kind of step back, and we have a lot of dental students that listen to the podcast. So maybe and denotate the different types, and then we'll kind of take a step back and go back to Cements 101 a little bit.
Sure, that's a good idea.
Yeah, so maybe high level, we'll talk about zirconia. So like we were talking about earlier, it's very important that you're pre-treating that restoration material correctly. A lot of challenges, and a lot of times I hear from customers that sometimes they get zirconia debonding, and you find out later on that they're not doing the proper pre-treatment steps, or that there's been contamination after try-in. And so really the appropriate thing to do with zirconia is to sandblast that material with a 30 or 50 micron aluminum oxide at a pressure of about 2 bar until you create that matte surface appearance. And what that's going to do is that's going to prepare the zirconia for chemical adhesion to a resin cement, or it's going to make it micromechanical for your glass ionomers. And another thing to note about zirconia is that those zirconia surfaces are, once they're prepared from sandblasting, they want those phosphate groups. And if you try in a zirconia crown and you get saliva or blood contamination on that surface, that can actually bind to those zirconia sites, and that's going to prevent the resin from binding or bonding to that zirconia material. So it's important to clean out your restorations if you try them in with, either a water or a sodium hypochlorite solution is what we recommend. And there are some other products on the market that work just as well for cleaning that zirconia before your final cementation procedure.
Interesting. So I mean, zirconia is probably the thing to talk about, although I would love to go back and talk about lithium disilicate too. But
yeah, absolutely.
Zirconia is what most people are putting on there. And let's say either cement, you're going to want to sandblast it. Would you do try-in first, then go back and sandblast it? Or do you feel like sandblasting prior to try-in and then you can just clean any contamination after that with whatever you're using?
So I would sandblast first,
okay,
and I would clean out the residual, aluminum oxide particles with like an alcohol and water and air dry, then try it in, and then clean out the restoration. And I know it sounds tedious, but it's very important that you take those steps. One, you want a well-fitting restoration, and two, you want to make sure that that surface is perfect for either conventional cementation or bonding cementation protocols.
Okay,
So
and that gets it ready to bond for both of them then?
Yes.
Okay,
and,
go ahead, John.
Maybe, yeah.
Yeah, I can interject a little bit. So most of your labs are going to sandblast that for you. That's part of their protocol. So almost every zirconia crown that lands in a doctor's office has already been sandblasted to spec. So you can take that and try that right in. But Dylan's right. The minute saliva hits that, it's full of phosphates. It contaminates the zirconia surface. So you have to, reflood that with zirconia oxide with some kind of a cleaner, or you could just use, like you said, sodium hypochlorite. As long as it's rinsed very well, alcohol works pretty well too. And what I find is I can get a tooth isolated and clean a prep, and I'll scrub the prep, and then we'll disinfect the prep, and then we'll isolate it to be dry. So when we try in, sometimes if you're trying in on a dry tooth, there's no need to go back and have to clean that restoration. So if you can get a dry site, it's great. But like Jason was saying, sometimes the isolation is not there. It's a wet area. Sure, just try in the crown. It's no problem. In zirconia is in the back of the mouth usually is where we're using it, where it's going to be wet and challenging. But if you can get it dry, you don't have to prepare it again if it's already been cleaned. If it's wet and gets contaminated, then you do have to take that step. And so that's an easy thing. It's no stress. We just go ahead and clean it. So we have the cleaners ready to go. Depends on, I look inside, and if I've contaminated that surface, then I'm going to prep it a little more before we cement. And,
what's your typical cleaner, and how do you deliver it? I'm talking chair side here. I'm talking for ease of use. What's your typical cleaner?
Yeah, well, we're using an IvoClean, which is a zirconia oxide solution, and we'll do that for 40 seconds and just scrub it in there.
And you just use like a micro brush or something like that?
Yeah.
Okay.
Yeah, that's it. It's a 40-second activation. Just clean that up, rinse and dry it, and then you're ready to go.
Okay.
Because they're already sandblasted, like I said. So people sometimes get concerned about that, and they feel like they got to get a sandblaster. A lot of places, a lot of offices are simple. They don't have that equipment. So just understand that the labs are doing that. That's part of their protocol. So,
what are you using to disinfect your prep? I know you mentioned that.
Yeah, well, first thing we do when we take the existing temporary office, we get all the cement removed. Usually we're using a brush and some pumice, and then a little Paradex to scrub that surface. And then we'll go ahead and rinse it really well. And then we're basically an alcohol wipe sometimes on the prep, or even I have used dry bond before, material called dry bond, which is like a dental acetone. And we'll wipe the prep off with that. Depends on how contaminated it is. And then sometimes if we have a hypersensitive tooth, we'll use a little bit of glutaraldehyde on the tooth to just re-wet that dentinal surface and kind of desensitize the tooth if we need that. I don't find I need that as much with my like Unisem 2. We get very low sensitivity rates, so we don't have to do that very often, but you can do that if you have a patient that needs that.
We had a good discussion on the Dental Hacks Nation the other day. Kind of people going back and forth whether they numbed for every crown prep or not, or every delivery.
Sure.
And there was a lot of good discussion about that and things to decrease sensitivity. So
yeah, one of the hacks that we do is we don't numb a lot, but we instantly, once we get the temporary off, we'll get some gluma out. We'll wipe the tooth down with a gluma, and they almost all patients will get relief almost instantly from that. Then you can continue to work a little bit. We might do another wipe after that. And that's also a little bit of a disinfectant step as well as desensitizing.
I like that.
Another dumb question: Are you air drying the gluma after that? Or are you leaving it?
We tend to just blot it until the excess is gone. We don't really need to air dry that unless you've got some liquid sitting there. So we use micro tips and just keep blotting that, or a cotton pellet is fine.
Okay, so you've got a tooth that's ready to go, nice and dry and isolated. You've got a cleaned crown. Let's just talk a little bit about, let's say you're going to use luting, RMGI. You're basically, do you have to do anything else to the tooth of the crown before you go right from the syringe into the crown?
Are you asking me?
Yeah.
Oh, yeah. No, not at all. So basically, once you have that crown prepared, that tooth surface prepared, you would just dispense a little cement out, make sure it's mixed properly, and then cement right into the crown, seat the crown. And I would recommend tack curing the excess, remove the excess, and then, it's a short 5 minutes after that to let the material set, and you can send the patient on their way. It's a very similar procedure for the Unisem 2 product as well. So that's the same thing. Once you have everything ready to go, you cement, seat, tack cure for 1 to 2 seconds, depending on your preference. And then basically you let that material self-cure as well, and you're good to go. So it's very simple once you have all those proper pre-treatment steps done.
I'm probably doing it the wrong way because I usually do, but when I see my crowns, I have the patient bite down on a cotton roll. So is there any concern with tacking? You're tacking some of that material, so some of that material is hardened, and then on the inside, some of it's not. Is there any concern with biting down on a cotton roll at that point and compressing some of it, or is that even a thing?
And from my point of view, I wouldn't view it as a concern at that point. I would just make sure that the restoration has been fully seated when you initially place that cement before tack curing. That way, so, light finger pressure and making sure that it's fully seated, and then keeping that finger pressure on the restoration and tack curing the excess. That will initially harden the cement around the outside of the crown, especially with your self-adhesive cements, and then after that, have the patient bite on a cotton roll, and you should be okay.
Jason, I would just make sure you never spot tack before the patient. If you're going to have them bite, that's fine, but don't spot tack until you have them bite. So you can put a cotton roll in, have them bite down, and then you can kind of lift the cotton roll up, keep their teeth together, and do your spot tack with the cotton roll in place. I don't think it would be smart, because you know how crowns are. As a clinical dentist, we think the crown is seated and the patient bites, and that microscopic, a little bit further seating occurs that you can't do with your finger. Sometimes that can happen. So if you're using the cotton roll technique, I think it's great, by the way, but you have to make sure you're not going to spot tack and then have them bite down on the cotton roll. It's probably better if you're going to seat it with a cotton roll, that's fine. And it's harder to get in a spot tack. Well, what I'll do is spot tack the buccal, and then I'll let them open and spot tack the lingual. So now I know the crown is in place and the cotton roll stays there, because sometimes you've actually tacked the cotton roll and the cement's all combined. Yeah. So it's actually kind of slick, because the cotton roll, if it's touching the cement when you spot tack, it's fine, leave it there, cure and spot tack the lingual, have them bite back down for a few minutes. Then when you pop that off, the cotton roll brings the cement with it sometimes too.
Yeah. Bonus.
So on a good day. When
the thing about Unisem 2 is a lot of people tried all these different techniques to clean it. They start wiping it up, they start blowing air, do all that, and it just makes a complete mess. And it's better to leave it as a bead and just do that 1 second tack cure and pop it off, and then you're fine. So.
I was shocked shocked how, I got to tell you, I avoided resin cements for a long time because, I mean, maybe I'm crazy, but you guys remember that resin cements used to be a freaking nightmare in a lot of cases where it was just like, oh my God, I don't want to do this because first off, the instructions were like 4 pages long and you felt like I remember some of them you'd have the syringe was something it had a screw on the top and you were supposed to screw like 2 drops exactly in the thing. I'm like, oh my God, this is like rocket science. And now I'm like, I literally opened the package of Unisem 2 and it looks the same as the RMGI. I'm like, whoa. I mean, like it's a syringe with a mixing tip. It's exactly what. So I'm curious about that from the 3M standpoint. You guys have gone to great lengths to simplify this for us, is what I'm guessing. Tell me a little bit about that.
Yeah. So, one thing in the past, and this was before I was at 3M, but we did a lot of customer sessions and voice of the customer. And what we heard from them was that, these procedures are way too complicated. There are too many steps. It's hard to use. And so we've been actively working to simplify that procedure. What we find in simplifying the procedure and making things as easy as possible is that there's less risks for misuse of the product and less chance that something goes wrong. So the simpler you can make something, the faster you can get in and out of the patient's mouth with a great clinical outcome. And that's what we're really focused on, is helping the dentist simplify their procedures on a day-to-day basis.
I know in the past, sometimes it's been mentioned that sometimes the product is kind of compromised because we're trying for that simplification and you're trying to find a
interesting point.
fine balance of decomplify or
right,
getting rid of the complications. And so obviously a lot of it is user error. You find you're kind of at that sweet spot now with the technology and able to do these things a little bit more?
Yeah, absolutely. So, our chemist worked hard on developing a technology that would work and be simple to use and have great clinical outcomes. We were the first self-adhesive resin cement on the market, so we have over 15 years of clinical history with that product and just some recent reports, and there's been great clinical success with that. And that's credit to our R&D developers who really worked on the chemistry to make something that's really simple to use, as well as providing those long-term clinical outcomes.
Is there any scenario where you're adding an extra etchant to some of those procedures? I know in the past I've heard, and this was years past, some of the cements, the self-etching was not quite strong enough to truly etch.
That's a great question. John, are you ever using a bonding agent where you're etching and bonding in advance because maybe particularly non-retentive prep or something like that, or has Unisem 2 gotten rid of that deal?
No, absolutely. We're using a bonding step when we want to get that little added edge, and it's really simple now with the self-etching adhesives too. You can just all in one motion. You don't even have to use etch. You can just use a self-etching adhesive because most of the time you're working on dentin with a full coverage prep. Mm-hmm. So etching full dentin doesn't really do, can be detrimental. So using a self-etching adhesive is wonderful. You just wipe it on there, air dry it, light cure it, and then you just cement like we were just talking about. As long as you don't have any of that resin pooled anywhere to prevent fully seating it, you're good to go. So
if you wanted the added retention, you would use a real clean self-etching bonding agent and call that good prior to, say, a self-adhesive like Unisem 2, something like that.
That's right. Unless I was going to go, if I had enamel areas on a partial coverage crown, then I would go ahead and etch those enamel areas selectively.
Okay.
And then because you get much better bonding results to etch
sure.
enamel, etch separately. And then I would probably move then to a true dual cure resin cement. If I was going to do that scenario, I wouldn't use Unisem 2. Unisem 2 is kind of my full coverage cement. And, simpler is not always better. We were just talking about that.
Mm-hmm.
If it's too simple doesn't mean it's going to be better. But for me, that Unisem 2 has just been the simplest thing I've ever, and that's why resin modified glass ionomer kind of went away in my practice. I just don't, except for only reason I would grab it is for the fluoride release, and I just don't find I need that very often.
Mm-hmm. Interesting.
So we keep it really simple when we get that shorter prep. We want more retention. We're still using Unisem 2 just like we did on the regular preps, but now we might use a bonding step in there to benefit that a little bit more. And we may even consider going to the full resin dual cure type cement instead of Unisem 2, but the research says you can do that with Unisem 2 as well. And that works well.
Okay, so Dylan, I'm going to actually put this one to you then. So we're kind of segueing into a straight up dual cure. I want you to tell. I guess let's step back. Let's talk to our
Sure.
dental students or our new dentists or people who aren't thinking very hard about this stuff. What's the difference between a Unisem 2? I know, I get it. Unisem 2, which is self adhesive, versus a straight up dual cure. Because I'm curious to know we're going to get into talking about Ultimate, I think it sounds like, but I'm curious to learn about what do we need to know about those two things and the difference between two of them.
So the difference between like a self-adhesive and fully adhesive cement.
Perfect. Yeah, exactly.
So so Unisem 2 is a dual cure material. It has both the light cure.
I'm sorry. Yeah, I wasn't using the terms correctly. I need to make sure we're being straight about that. Yeah.
Yeah, both dual cure materials. The aspect of Unisem 2 that's most important is that we wanted to simplify the procedure. So it's a self-etching material. It has a phosphate monomer group that helps etch the tooth and bind chemically to the tooth surface. And we wanted to simplify the procedure in order to reduce steps or reduce the chance of post-op sensitivity and contamination, something simple. The difference between that and a full adhesive system is that our full adhesive system, like the Ultimate, requires that Scotch Bond Universal is what we pair it with. And that's going to help give you the high bond strength to the tooth surface, the immediate sealing of the dentinal tubules, and then that long-term clinical outcome as well. So there's a slight difference. Unisem 2, we really don't recommend using an adhesive with that, just because we wanted to simplify the procedure for that specific material. It's kind of your everyday go-to cement.
Mm-hmm.
But in the case where you want to do almost all indications, any type of restoration, whether it be stainless steel, PFM, zirconia, glass ceramic, Ultimate can be used for that. But there's trade-offs, right? So it takes more steps, more time consuming, and sometimes you don't need all that extra retention with an Ultimate type product.
And Dylan, you also need an isolated site when you're using the bonding step. So
Absolutely.
That's kind of the one thing for me when I can't isolate. I'm not thinking bonding step because I don't have the ability maybe to keep it dry and clean. So Unisem is perfect because I need a couple of seconds of a dry tooth and I can get that down and spot tack and I'm good to go. When I go to my bonding resins, I'm going to go to the dual cure almost always. And I'm going to have a clean area that I can work with and things like that. So,
yeah, and John makes a really good point. Like when you're using an Ultimate type product in that full adhesive system, it's really important to isolate and keep that field dry. Sometimes pooling of saliva and blood, that can really inhibit your bond strength. I think we referenced that earlier as well.
Mm-hmm. Mm-hmm.
In the past, I've used the dual cure initiator with the Scotch Bond. Is there any indications for that? Some sites that are harder to cure, or is that still a thing?
So the interesting thing with our Ultimate product, the cement itself has that dual cure activator in it. And so what that's going to allow you to do is basically, if you don't light cure that adhesive, that dual cure activator in the cement is going to cure the Scotch Bond Universal. Now, it would be different if you were trying to use a different adhesive system with Ultimate, but we would recommend that those two are paired together. They were both developed pretty close together in our R&D community, and that allows those products to be used together pretty interchangeably.
Now, is this something you would advise for using in like fiber posts and endo teeth, or?
For fiber posts, the difference is that you would have to use Scotch Bond Universal on a fiber post with Ultimate. And so what I would recommend is using Unisem, because that way you can just cement in the canal itself, seat the post, and then go. You don't have to use an extra adhesive. And I don't know, John, if you want to comment.
Yeah, John, weigh in on that. If you're going to use a fiber post, what's your go-to? So
I'm only using fiber posts, by the way, now, and I used to not. That's kind of a new thing.
No more screw posts. Those are awesome.
Yeah, those are great. I love those, right? But everybody did. They're easy to remove.
Yeah, exactly.
So the deal with fiber posts is, you sort of have to draw the line. Okay, so this is simple, straightforward, lots of two-structure fiber posts where you're going to slide it in, and you don't need a lot of adhesion. You can use Unisem too, I think. But if you're going to do one of these posts where there's a minimal two-structure and you want to have more strength and add strength to the tooth, to me, using a bonding step and a full dual cure resin is going to be the choice that I make. And I do that most often because I want the best adhesion for a post I can get. I've seen so many patients come in with a crown in their hand and the post attached to it, and it's come loose from the tooth. We've all seen that, right? So why not go ahead and bond that? Dylan's right. You can use the Unisem too, keep it simple, but for me, I'm going to go ahead and most of the time I'm going to bond that post in. So I'm going to coat the post with a self-adhesive resin like Universal, and then place the Reliax Ultimate in the canal, and then just seat the post and do the light cure. And I do use Unisem when it's, like I said, when it's straightforward, sliding a post down a well-treated tooth that has lots of tooth structure.
Mm-hmm.
Most of the time it's compromised, and I have a bigger opening than the post sometimes, and I want to go ahead and dual cure bond that.
And I think this brings up a good topic, John, but there are different cements that you'll need for different types of basically clinical cases, right? You may have one patient who has a good retentive canal and you're not worried about tooth structure there, but then in the other case you may not have a lot of tooth structures there, so you may need that fully adhesive dual cure.
That's exactly right.
Sometimes on these podcast interviews, I come up with great product ideas. So I'm going to pitch this out to 3M. But they make the McDonald's version of cements, where I get a box and it's got a picture of a zirconia crown on it, a picture of a post on it, and a picture of this other. And each slot has a cement in there, and I peel it back. Oh,
I like that, but I have to admit the instructions that 3M has put together. They stopped using words, which is good. They've gone the IKEA way, and I will tell you that is great, because you know what, dentists we're not going to read that stuff. Pictures are what I'm looking for. Honestly, I do say it's almost what you're describing, Jason. It's almost there. I do like that a lot.
The McDonald's cash register with a picture of the hamburger on it with one pad.
Exactly. We don't need language here.
The other thing I might add about posts, if you have a short post, you're going to want more retention for that. You're going to always want to bond that. If you have a big long post, then Dylan's right, you can use Unisem too. But on these little short posts and you want more retention, go ahead and use the self-etching adhesive and use the Reliax Ultimate. It's a great combination. Works really well. Sometimes
I would put the build-up material you're seating the post, and I'm putting the build-up material on top of it, kind of around. Is there any contraindication to that? Or the two materials going to bother?
It's a great question.
So you're talking after you've seated the post and putting the core buildup on top? No. So, as long as you're applying an adhesive and following the steps for the adhesive on the top of the post, it should work in combination with that composite. There should be no cross interaction between that. So, both of our cements, whether it be Unisem or Ultimate, they're both indicated for post and core procedures. Not obviously a core buildup, but, post, and then obviously using your core buildup material on top of that.
Sure.
Or composite or whatever you choose.
Composite, yeah, exactly.
Okay, so I'm going to go back because we sort of talked mostly like zirconia or retentive, say gold or porcelain fused to metal, but I want to know, because there's a lot of people that still use they use Emax for all kinds of crowns, whether it's posterior or even further forward with that sort of thing. What kind of differences? I mean, John, when you're doing Emax, let's not say veneers or anything like that, but like on a retentive prep, what's your typical go-to, and how do you treat an Emax crown differently than a zirconia crown, or is it more or less the same thing?
For me, if it's got full coverage and good retention, it's Unisem 2 every time, or a self-etching, resin cement, because it's going to bond even better to the tooth structure or to the crown. Inside of the crown, the resin cement will bond even better than it does to zirconia, because you've got a nice etched, a ceramic surface. And all we do is apply a ceramic primer to the inside of the Unisem, and that's it, to the inside of the Emax, and that's it. And then
Okay. Similar try-in stuff where I'm assuming similar try-in stuff where you clean it all out before you go to the final cementation.
Exactly. You do need to clean that if you've contaminated that surface, and then apply your primer, and then you're ready to go with your self-etching resin cement. And you can bond that too if you had the typical short kind of prep thing. Then you would add your adhesive component to that, and you'd actually apply the adhesive component to both the crown and the prep, and air dry both. And I usually will light cure the prep, but not light cure the crown itself before I load the cement.
Okay.
So,
and that would be, that's kind of, go ahead, I'm sorry.
And we would use go to the dual cure cement on that scenario where we're going to need that extra retention. We're going to move to the Relax Ultimate or the fully dual cure bonded resin cement.
And so that's like probably a lot of people doing Cerex that are sort of minimally invasive, where we're not doing a crown, but kind of a minimally prepped onlay. That's what we're sort of talking about here. Right. And it's, I mean, I know they can do zirconia chairside, but so much of it is more of a lithium basilicate thing. Mm-hmm. So that's the kind of thing you're talking about there. I like that.
Yeah, and the nice thing about lithium basilicate is it does bond really well, and it's a wonderful material. So full coverage, it does great. And for me, I would never choose to use probably a luting, like an RMGI with that scenario. For me, I'd always go with a Unisem 2 or a dual cure bonding resin in my practice.
I've seen recently some of the more progressive lab guys are actually doing stuff with pectin for resin bonded bridges and different materials. So
that's right.
How are you guys looking towards the future for that as far as things are coming out?
For pectin?
Pectin, correct.
I'm actually not familiar with pectin, so if you can give me an overview, I guess I can.
I just know the name. I don't know the.
He was dropping names. Sorry, we don't know anything about it.
Like a milled
jelly beans, isn't it? Something like
that. Milled peak material.
Okay. Peak material. So yeah, that's something a little bit newer. It would be kind of more towards the composite, I believe, aspect of types of material. But so in those cases, when we talk about material strength, and I'm sorry, I'm not as familiar with this peak material as most, but
I just try to sound smart sometimes.
Yeah,
it's a rare thing.
Nicely done, Jason. Nicely done.
I as you start talking about material strength, in glass ceramic cases, they're generally a little bit lower or weaker materials, and similarly with composites. If we're to start talking about those weak, quote unquote, classes of material or weaker classes of material, I would lean towards a fully adhesive resin system, because that's going to give you the best bond strength. It's going to have physical properties of that material itself that not necessarily an RMGI has, such as higher flexural strength and higher compressive strength of the material as well. And that transitions into Unisem 2, for example, too.
Very cool. Thank you.
All right. So the one thing we haven't really talked about here, and this is, I know there'll be a lot of people that want to hear this story. And John, let's go right to it. We're talking about veneers. Let's say you're doing either a feldspathic. Well, okay, let's start with it. Do you do feldspathic veneers still in certain cases?
Sure, we do on the minimal prep or no prep stuff. That's the best material to use.
For sure. So tell me how. I know for your career and my career, they've talked about color, the problem with material changing color underneath, or try-in gels and all this stuff. Like, bring us up to 2018. What do you like to use for that?
Well, for me, I don't even use the colored cements ever, because the change you can make is so minimal. The film thickness is so minimal that it's hard to make a difference in that. So it's always best to try to get the lab involved to get the restoration the right color.
Yeah, exactly. Yeah.
We just try in with water usually. If you're starting to use colored cements, it can get a little tricky unless you have a greater film thickness or you create that by prepping more tooth away. So for us, when it's feldspathic porcelain, it's these minimal prep cases, not big color changes. And that's been around for, 50 years, maybe longer. They've been doing that. There's cases documented that far back. That was the first veneer. Everybody thinks lumineers and this is all a new thing. It's not a new thing. That was the original porcelain veneer that was there in the beginning. And that's a great, very durable. It's all enamel bonding. Those things just last. The only thing that breaks those is a heavy brux or somebody like that. So that's the contraindication, is if you're extending a lot of length on a patient with a feldspathic veneer, that's not a good choice. And bonding those is super straightforward. It's like bonding a composite restoration. It's a total etch scenario. The tooth should be totally white and etched perfectly. There's all kinds of enamel everywhere. And then you treat the tooth with your resin of choice, and then you treat the intaglio surface of the veneer with really now all you need to do is use a ceramic primer. You don't even need to coat anything inside.
What ceramic primer are you using with these guys?
I'm using the 3M ceramic primer
Sure,
that
sure.
they sell. The thing about ceramic primer is sometimes it sits in the drawer a bit.
Yes.
So people need to be aware that you need a in-date fresh ceramic primer, or it's not going to do anything. They call it silane primer is what you might want to call it. And then we'll just coat the inside of the veneer with the silane. And then we don't even put any resin inside the veneer anymore. The research shows that's an extra step and it doesn't add to the bond strength. So you can even skip that step now and put the resin cement straight into the veneer and seat that on the tooth. So it's really simple. And I mean, some people are even, I mean, I wouldn't do this, but they're skipping the etching step on the tooth, and they're not total etching with phosphoric acid. They're using a self-etching adhesive. The research shows you're going to get a much better bond if you use phosphoric acid and etch that enamel. Anytime you have enamel, you should etch it as a separate step. You're going to get a better result.
Sorry, would they get those black lines on there if they don't etch with that, or is that a concern?
Yeah, that's almost always, that's a bond failure, Jason. You know that. So I always tell people, etch all the way up when you have enamel available. And even if there's dentin, I mean, we're going to etch that dentin too for a shorter amount of time. 5 seconds versus 10 seconds. Black lines.
Oh, go ahead. I'm sorry.
Yeah, black lines are, can be a problem. You don't see them that much, and that's patient environment related too. If you have a very dry mouth patient, acidic mouth patient, you'll see that more often.
I love the fact that you talked about the colored cements and how you just don't want to do that anymore. I've always thought to myself, I am not that good. I'm not. I can't figure the color.
Don't say yourself short, Alan.
Get the lab figuring this stuff out, and then I'm gonna adjust the color as well. I'm like, give me a break, And so when you're using that, you use the straight up translucent stuff, so you're not adding any color.
Yep, every time.
Yeah,
almost 100% of the time.
Well, it simplifies your armamentarium. You don't have to have a bunch of different colors for crying out loud. I mean, you remember those resin cement systems where you'd have like 8 syringes of all these different colors. I'm like, man, I am just not that good. There's no way. So I love that you say that.
Yeah, and understand that feldspathic porcelain, labs have the ability to control that color in very fine layers because they're using powders and things like that. So if you provide the color of the prep to the patient, to the lab, the patient's prep color, they can do a lot there, and that's really where it should happen. And cementing with a translucent cement on a feldspathic veneer gives you the best depth, and the reason you're doing that is to create natural look, so you want some color to come through and things like that. If you have a darker tooth and you're trying to make a shade change, you got to have that conversation with the patient. If they're going from an A4 tooth, they want to go to an O2O on, you're going to have to talk to them.
Yeah, because you're going to have to prep more tooth at that
exactly
point.
Right.
Yeah, exactly. Or you could make them super bulky. That's always nice.
Yeah, and then the material changes too. You're not going to use feldspathic. You could, but you're probably going to go to lithium disilicate.
Well, that's a perfect segue. Let's say you've got a case with lithium disilicate veneers where you've done a little bit more preparation. Are you doing anything different with a veneer than you would for the crown? What's your material go-to choice there?
It's the same exact procedure for me. And I think the one thing we didn't talk about was cement changing color. So if you're going to use a dual cure cement, there is a possibility with a veneer to have a color shift. So we always recommend pure light cure materials when you're dealing with veneers.
Yep.
And so when I go with lithium disilicate veneers, it's the exact same procedure. We're going to totally etch the tooth. We're going to apply our resin, and then we're going to air dry that and light cure that tooth usually, and then or not, depends on your comfort level with that. And then the inside of the veneer is ceramic primer, and then the resin cement goes straight in there and you seat it and wipe it up. The nice thing about light cure obviously is you have control of cleanup, and you should try to clean up as much as you can before you light cure. It's much easier than leaving a lot of that cement there. So that's the difference with a pure light cure scenario.
What would you suggest for some of our listeners as far as taking the shade on like a stump shade or the prep shade? I know probably a lot of people don't have a stump shade shade guide.
So the lab just needs a reference point. So the first thing you got to make sure is that the tooth is moist, because a dry dentin shade is quite a bit different than a wet dentin shade. So it's important to just moisten the tooth with a cotton roll with water or anything like that before you take your photograph. And then you can put any shade guide up there you have. You can use your Vita shade guide or your 3D shade guide, or if you have the stump shade guides by Ivoclar, those work well too. And it's just a reference point. It doesn't have to be an exact match. You just have to put something up there to give the lab the reference of this is what this prep looks like.
So they're looking more for the value of the darkness and
that's right. And then you have to give a reference of where you're going. This is the color I'm going to. This is where we're starting. And then you need to understand you need to create clearance when you're making bigger color changes. There needs to be a deeper prep.
Can I suggest that when Ivoclar started calling that shade guide the stump shade guide, that they made a mistake calling it a stump? Because whenever you ask for the stump shade guide when patients are there, they start getting sweaty about stump. What stump are you talking about? What did you do to me?
It's actually stump with an F.
Stump. Yeah. I've not ever been able to explain that. By the time they've heard it, it's too late. So yeah, I think probably prep shade guide might work a little better.
We call it dent and shade.
There you go. There you go. You're taking care of these stump. What did you do to me? All right. So
I never use that around patients for sure. You know?
Seriously. Okay, so one thing you said, so you're going straight light cured with the veneer stuff in a lot of cases. I know 3M's like, oh, we don't have to worry about the products, but you guys are here. I want to know what products you're talking about. Is there what product is straight light cured from 3M?
We do have a dedicated veneer cement.
Okay.
So it's a dedicated system that's a light cure only material, because we heard from the customers that they need that working time and that flexibility.
Yeah, for sure.
The nice thing about this system is that it also has corresponding try-in pastes, which are water soluble. So if the clinician decides that they do want to do some playing around and see what best shade match they can get, they can use these try-in pastes that are designed to match the final color of the cured cement exactly. And they can try it in, and then they can see, hey, does this match? Or no, it doesn't match. And they can just rinse out that try-in paste with water and then use the next shade and then cement and light cure and go. And all the steps that John was talking about earlier.
But they also have a translucent in that, I'm guessing, too. Is that right?
There are 6 shades available, I believe, in the veneer cement system.
But the light cure then gives you you control the time, but also you have less worry about the dual cure changing shade underneath the veneer.
So in the past, the resin-based cements and the adhesive resin-based cement systems were using an aromatic amine, and this was years ago. And during that time, what the aromatic amine can do is it can discolor and it can degrade over time. Now, a lot of manufacturers, including ourselves, have moved away from that aromatic amine chemistry, and that's greatly reduced the chance of that discoloration occurring. However, when we talk about veneer cements, we would always recommend going with a dedicated veneer system regardless, because it gives the clinician that working time and flexibility and ease of use that they require for doing some large cases.
Yeah, and the problem with using any kind of a dual cure for veneers is that you usually have multiple restorations. So if you're seeding multiple restorations, this can happen when you're seeding multiple crowns. You have 2 or 3 crowns in a row with Unisem 2 or any kind of dual cure resin, and it starts to get a little bit tricky to get everything cleaned up before it starts to set. So you want the control of a dedicated light cure system when you're using veneers, so you can make sure they're positioned properly, cleaned up well, and things don't start, setting on you while you're in the middle of that. It's real important.
Absolutely.
And turning off the overhead light and turning off lights that are attached to loops and microscopes, and using, being very careful with that is pretty important. So put the light on the chin, keep it out of the mouth. We're doing everything with a microscope, so we just put the orange shield on and you're good to go, and you can see what you're doing really well. So
nice. I didn't know you were a microscope guy. What kind of scope do you use?
Zeiss.
Nice. Okay. Very nice.
What happens with microscopes? Kind of funny thing. I mean, I had them in the practice for the endodontist, and one day I just pulled it over to dig a screw out of an implant or something really small you couldn't see in it, and it was like lickety split. I thought, well, that's kind of cool. Oh, look at that crack on that amalgam. Then I started, this was 10 years ago, I started doing a case here and there, finishing margins with it, and pretty soon, once you get used to it, it's just like giving candy to a kid. You just can't hardly not do anything without it. At this point, I'm so into it. I can't. Now I do everything start to finish.
That's I'm similar. I have actually here's one. I'll do you one better. I have them in my hygiene operatories, because I would argue that you can your documentation through them is much better than anything you can So basically, there as I'm teased often that I have $25,000 intraoral cameras in my hygiene rooms, but I love them. I literally videotape all my exams and stuff. It's crazy.
And you think you clean up cement well. You get a microscope and you clean a tooth with your loupes or your bare eyes, and you get a microscope on it, and there's tags of cement everywhere.
You ever notice it with the microscope when you're really up close? You figure if you can get it looking pretty good in the microscope, and then you go out to like your regular eyes, and it looks ideal. It's amazing.
Yeah, it looks amazing.
Your standards get really weird when you're working under a microscope. There's no doubt about that.
That's the only bad thing.
Everything looks like crap. Great, excellent. I'm sorry, Jason. You had a question. It sounded like.
I was just going to say, Alan just developed a man crush.
I was going to say, Dr. Weston. We have to talk.
I know. It's definitely a microscope club for sure.
It is. But it is funny that we're talking about all these different light curing and dual curing, and the microscope is like looking into the sun. So your point is well taken by having good filters, or LED headlamps that tons of people have. Those are also very intense. So you really have to be. If you're worried about your set times at all, you have to be really good about that and turning lights off and stuff like that. I totally agree.
I know we're getting towards the end here, and I know you just mentioned looking at an implant screw. So how would all this fit into
question
placing implants? Or
yeah.
Matter all that much as far as if you were doing a cement or a screwman tapeable.
Well, first of all, the only crowns that we're cementing on implants, if we're going to cement a crown on implant, it's going to be on a custom abutment where we can control where that margin is. And that's super critical. And now with the digital workflows with implants, there's absolutely no reason not to have a beautifully cemented crown, because you can control where that margin is, put it right at the tissue, and it's not down there where the interface of the implant is in the bone. And that was the problem in the past with cemented restorations on implants, is the abutments were typically not custom, and the patients, the doctors are cementing these crowns down and shoving cement down around the implant.
Sure.
So now with these design, the digital workflows, you can design and put that margin way up where you want it, right at the tissue level. And I know a lot of people use the resin modified glass ionomer for cementing those crowns onto the abutments. We just use a light coat of Unisem 2. It's perfect. It holds really well. So that's, again, I'm down to that one cement for pretty much all my stuff. But the key with cementing crowns on implants is margin placement, for one, using very minimal cement. In fact, sometimes you can seat the crown, take it back off, clean the excess cement away, and then drop it back on. Or you can use a die outside the mouth to seat the crown on and kind of get rid of the excess cement. You just don't need a lot, and you don't want a lot. Just minimal amount.
I love that die outside the mouth. When I first heard about that, I thought that can't possibly work. It works awesome. It works really great.
That and just a thin coat inside is fine.
Mm-hmm.
Yeah, John made a great point there. It's that, with that excess cement, and especially if you're not careful about your margins, you can get that cement down into the sulcus, and that can cause a lot of issues. So definitely, if you're doing a method that's not similar to John's, you want to make sure that you're cleaning out that cement from the sulcus, or at least being as careful as you can, because you don't want to have those issues at a later date, or a patient coming back in with inflammation or other problems. That's the last thing you want to see as a clinician.
Yeah, and Jason, one last thing, about implants. People ask, well, why do you cement your crowns on implants and even risk that? Well, I'll tell you, patients spend a lot on implants to have an implant done. And when you get done and there's a dot in the middle of the tooth that's kind of dark, they go, what's that dot in my tooth? I paid $3,000, $4,000 for this implant crown, and there's a hole in it. Well, it's not a hole, it's where the screw is, and blah, blah, blah. But bottom line is, I like a cemented restoration on an implant because it looks so natural. But again, margin placement's critical, cleanup is critical, and you can't stuff a crown down on an implant with a deep margin and expect that to be healthy for the patient. You can really confirm the cement's clean. So that's the reason I choose cemented restorations on implants, because the patients like how they look, and that's the ultimate goal, is satisfying.
Sure. If you are doing screwmentable, that is the conversation. The time to have that conversation about the hole in the top of the crown is before.
Yes, exactly right.
After is the wrong time. It's too late at that point, for sure.
And they are not happy with
us. No, that's exactly right. So, there's opacers and stuff you can work with, but I will tell you, the patient kind of needs to know that that's the case. And if that's a deal breaker, boy, you better deal with it in advance, for sure.
You're exactly right.
You guys, this has been spectacular. How can you talk about cements for an hour and not have it be boring? This was great, man. I was hanging on every word. This is awesome.
Yeah, thanks for having us on. It's much appreciated.
You bet. We really appreciate 3M being willing to basically all you engineers and stuff dumbing it down for the people that are actually cementing this stuff. If you guys have questions or comments for either John or Dylan about cements, when to use what kind of stuff, I would love it if you'd email us at info@dentalhacks.com. We'll make sure we get your questions to them, and we'll talk about it on the Dental Hacks Nation. But man, this was spectacular. I really appreciate your time, you guys. So thanks very much for being on.
Yeah, I really enjoyed being here. You guys are a great group, and anything we can do to help simplify for everybody out there, I think simplifying their cement armamentariums is huge for keeping the practice fun and easy. Yeah.
Absolutely. I echo exactly what John said there. Our goal is to make cementation easier for the clinicians and give them the best clinical outcomes as possible. So anything we can do to help, we're always listening to our customers for feedback and voice of the customer on how we can drive that next generation of products for them that help their clinical outcomes.
Very good.
Thank you.
Thanks a lot, guys.
Yeah. Thanks, guys.